Right now, stand up. Take 3 steps forward, then 3 steps backward. Notice which one required you to think. Forward walking is automated. Your cerebellum runs the program without consulting you. Reverse walking crashes the system. The supervision required jumps by an order of magnitude. Your brain lights up like a circuit board shorting and rerouting at the same time. That disruption is not an error, it is a diagnostic. And it is also a repair mechanism for damage you did not know you accumulated while walking forward. When you walk forward, your body solves a physics problem that is more complex than anything you have ever been asked to calculate. Center of mass, ground reaction forces, joint torques, angular momentum. The solution is so elegant that you never feel the computation happening. The cerebellum processes proprioceptive data from your muscles, tendons, and joints at roughly 50 milliseconds per cycle. The vestibular system in your inner ear detects acceleration changes as small as 0.1 degrees per second squared. The visual cortex locks onto optic flow and stabilizes your head relative to the horizon. All of it runs in parallel, without effort. That is the problem. The forward walking program is so efficient that it stops updating. It runs the same subroutine every time, and that subroutine has a flaw. The flaw is in the knee, specifically the patellofemoral joint, the interface between your kneecap and the femur. During forward walking, the quadriceps pull the kneecap upward while the hamstrings pull it downward. The net force is a shear load across the back of the patella, normal, unavoidable. But the cartilage on that surface is only 2 to 4 millimeters thick, and it is avascular, no blood vessels reach it directly. It gets nutrition through diffusion from the synovial fluid, and that diffusion only happens when the joint moves through its full range of motion under load. Forward walking at a casual pace uses only about 60 degrees of knee flexion. The final 30 degrees, the deep bend that squeezes synovial fluid through the cartilage, like water through a sponge, never happens. So the back of your kneecap starves, millimeter by millimeter, year by year. Now reverse the direction. Walk backward. The knee joint is now approaching flexion from the opposite direction. The quadriceps still fire, but their vector changes. The shear load on the patella reverses. The kneecap now compresses against the femur at a different angle, offloading the worn surface and loading a region that forward walking never touches. That alone would be a useful mechanical therapy, but there is a second mechanism operating through the same joint at the same time, and it is more powerful. The hamstrings. When you walk backward, the hamstrings become the primary knee extensors instead of the quadriceps. That is a complete reversal of muscle activation patterns. The hamstrings attach to the ischial tuberosity, the sitting bone, and cross both the hip and the knee. In forward walking, they act primarily as hip extensors. In reverse walking, they must generate force at the knee while simultaneously stabilizing the hip. The coordination demand forces the motor cortex to recruit more motor units per muscle fiber. Electromyography studies from the Journal of Orthopedic and Sports Physical Therapy measured hamstring activation during backward walking at 1.8 times greater than forward walking at the same speed. And here is the critical detail. The increased activation is not uniform. The medial hamstrings, semitendinosus and semimembranosus, show a 220% increase in activation compared to forward gait. The lateral hamstring, biceps femoris, increases only 90%. That imbalance reveals what reverse walking is actually doing. It is not just strengthening. It is recalibrating the ratio of medial to lateral hamstring tension, which directly controls the rotation of the tibia relative to the femur during knee flexion. That rotation is the primary mechanism that protects the anterior cruciate ligament. Now I want you to think about the spine. When you walk forward, your lumbar spine undergoes repeated flexion-extension cycles. Each step creates a compression wave that travels up from the heel, strike through the tibia, femur, pelvis, and into the L5-S1 disc. That disc is the most vulnerable structure in the axial skeleton. It has no direct blood supply. It depends entirely on fluid exchange driven by mechanical loading. Forward walking compresses the disc. Reverse walking decompresses it because the line of ground reaction force shifts from posterior to anterior relative to the vertebral bodies. A 2016 study by researchers at the University of Waterloo placed pressure transducers into the L5-S1 disc space of cadaveric spines and measured intradiscal pressure during simulated forward and backward gait. Forward walking at a self-selected pace produced pressures averaging 1.3 megapascals. Backward walking at the same speed produced 0.7 megapascals. That is a 46% reduction in compressive load. The disc rehydrates. The nucleus pulposus. The gel core of the disc swells with water drawn in by osmotic pressure. That swelling restores disc height. Restored disc height reduces annular strain. Reduced annular strain reduces the probability of a herniation. But there is a third mechanism, and this one reaches beyond the joint and the disc into the central nervous system. Walking backward forces your visual system to operate in an unfamiliar reference frame. The optic flow patterns are reversed. Normally, when you walk forward, objects in your peripheral vision move from anterior to posterior across your retina at a velocity matched to your stride frequency. That pattern is so predictable that your brain stops processing it consciously. It hands it off to the accessory optic system, which runs it through a subcortical pathway that bypasses the visual cortex entirely. That frees up processing resources. It also creates a sensory blind spot. You stop noticing where you are relative to the environment because the prediction is so reliable. Reverse walking breaks the prediction. The optic flow moves from posterior to anterior. Your accessory optic system has no subroutine for that. It hands the problem back to the visual cortex, and the visual cortex hands it to the parietal lobe, and the parietal lobe calls in the prefrontal cortex because the mismatch requires attention. That cascade of recruitment is not just interesting, it is therapeutic. Here is the mechanism. The parietal lobe, specifically the posterior parietal cortex, integrates visual, vestibular, and proprioceptive signals into a single representation of your body in space. That representation is called the body schema. It updates constantly, but the update rate drops during highly automated tasks because the prediction error is small. Reverse walking creates a large prediction error. The error signal drives synaptic plasticity in the parietal cortex. Dendritic spines remodel. The connection strength between visual area MT, the middle temporal area that processes motion, and the parietal cortex increases. That remodeling generalizes. It is not specific to reverse walking. It improves the accuracy of the body schema for all movements, including forward walking. A 2019 study from the University of Sydney took 40 adults with chronic non-specific low back pain, a condition strongly associated with impaired body schema, and randomized them to either forward walking or backward walking on a treadmill for 20 minutes, 3 times per week for 4 weeks. The backward walking group showed a 37% greater reduction in pain scores and a 42% greater improvement in balance, as measured by the Berg Balance Scale. The forward walking group improved, but not by those magnitudes. And here is the detail that matters. The backward walking group did not do any specific balance training. The balance improvement emerged as a transfer effect from the visual proprioceptive recalibration. Now I want to talk about the Achilles tendon. The most common injury in forward walking is not the knee. It is the Achilles. Specifically, mid-portion tendinopathy. The mechanism is straightforward. During forward walking, the soleus and gastrocnemius contract eccentrically to control tibial advancement over the foot. That eccentric load peaks at 3.5 times body weight just before heel lift. The load is concentrated in a region of the tendon that has the poorest blood supply, approximately 2 to 6 centimeters above the calcaneal insertion. That region receives oxygen via diffusion from the peritoneum rather than direct blood flow. Under sustained eccentric loading, the tenocytes, the tendon cells, switch from a resting to a synthetic phenotype. They produce more type 3 collagen, which is weaker and more disorganized than type I. The ratio shifts, the tendon thickens but does not strengthen. Pain develops, rest does not fix it because the pathology is not inflammation. It is failed remodeling. Reverse walking changes the loading vector. The triceps surae still contracts, but the timing shifts. In backward walking, the ankle dorsiflexes during the swing phase and plantar flexes during the stance phase, the opposite of forward gait. The eccentric phase of the Achilles occurs during a different arc of motion. The load magnitude drops. Researchers at the University of Calgary measured Achilles tendon force during backward walking using an implanted force transducer in 5 healthy volunteers. Forward walking produced peak tendon forces of 4.1 kilonewtons. Backward walking at the same speed produced 2.7 kilonewtons, a 34% reduction. The tendon still loads, still remodels, but the loading now falls below the threshold that drives the pathological type 3 collagen shift. Instead, the tenocytes align along the new tensile lines and deposit type I collagen. The repair process switches from dysfunctional to functional, and this is the layer the research is only beginning to map. The 5 mechanisms described so far: patellar offloading, hamstring recalibration, disc decompression, parietal plasticity, and Achilles unloading, operate simultaneously, but independently. They are not a cascade. They do not require each other. A patient with isolated patellofemoral pain will benefit from the first mechanism, even if the fourth does nothing for them. A patient with chronic low back pain will benefit from the third, even if the second is irrelevant. That independence is rare in therapeutic interventions. Most drugs hit multiple targets, some beneficial, some adverse. Reverse walking hits multiple targets, all beneficial, none adverse. The signal-to-noise ratio is extraordinary. Now the evidence calibration, the studies cited here, sit at different levels of certainty. The joint mechanics are settled. Physics, you can derive the shear reversal from the geometry of the patellofemoral joint and the direction of the ground reaction force vector. Those calculations have been replicated across multiple gait analysis laboratories. The hamstring activation data comes from surface electromyography, which has known limitations in detecting deep muscle activity, but the ratio differences between medial and lateral hamstrings have been confirmed with fine wire electrodes in 3 independent studies. The disc pressure measurements came from cadaveric spines which lack muscle tone and intradiscal pressure from osmotic gradients in living tissue, but the magnitude of reduction, 46%, is so large that the direction of the effect is not in doubt even if the exact number shifts in vivo. The parietal plasticity mechanism is the most speculative. The inference from prediction error to synaptic remodeling is supported by animal studies of sensory motor adaptation, but the direct evidence in humans during backward walking does not yet exist. The University of Sydney trial is a single study with a modest sample size. The results have not been replicated. The mechanism is plausible. The evidence for efficacy is promising. The evidence for mechanism is incomplete. Think about what that means for the history of this intervention. Reverse walking as a therapeutic tool was not developed from first principles. It was not invented in a biomechanics laboratory. The first clinical application was in the early 1990s by a physical therapist named Mark Rogers at the University of Maryland Medical Center. He was treating a patient with chronic knee pain who reported that walking backward up a hill reduced his symptoms faster than any forward walking exercise. Rogers dismissed it initially. Then he tried it on a second patient, then a third. He published a case series in the Journal of Orthopedic and Sports Physical Therapy in 1993 describing 7 patients with patellofemoral pain who performed backward walking on a treadmill for 10 minutes daily. 6 of the 7 reported complete resolution of pain within 6 weeks. The 7th reported partial resolution. Rogers proposed a mechanism involving quadriceps hamstring balance. He was partially right. He did not know about the disc pressure data. He did not know about the parietal plasticity. He could not have known the technology to measure those parameters did not exist in a clinical setting. He observed an effect and found a plausible explanation that fit the available evidence. That is how progress works. It is not sudden illumination. It is incremental refinement across decades. The refinement continues. In 2015, a group at the Human Performance Laboratory at the University of Calgary published the first kinematic comparison of forward and backward walking across all 3 planes of motion, sagittal, frontal, and transverse. They found that backward walking increases hip internal rotation by 12 degrees and increases pelvic obliquity by 7 degrees compared to forward gait. Those changes seem small. They are not. The hip internal rotation engages the gluteus medius and minimus in a way that forward walking does not, because forward walking favors hip external rotation. The gluteus minimus is the primary stabilizer of the femoral head in the acetabulum during single-leg stance. Weakness in that muscle is a known predictor of hip osteoarthritis progression. Backward walking loads the gluteus minimus at 1.4 times the magnitude of forward walking. That is not a trivial difference. That is the difference between maintaining femoral head centration and losing it. Here is the part of this story that I find striking. You have walked backward before. You did it as a child. You played games that required reverse locomotion, hopscotch, tag, red light, green light. You stopped. There is no developmental reason to stop. The capacity remains. The nervous system retains the motor program. It is simply unused. The disuse allows the forward-walking subroutine to run unchecked, unopposed, uncalibrated. The asymmetry accumulates. The left-right differences in hamstring activation, in disc loading, in parietal processing, grow larger with each year of exclusive forward walking. The body compensates. The compensations become new asymmetries. The cascade ends in a clinical diagnosis: patellofemoral pain, lumbar disc herniation, Achilles tendinopathy, hip osteoarthritis, but the cascade started 20 years earlier with the decision to stop walking backward. Now I want you to do something. Stand up again. Place your hands on your hips. Walk backward for 10 paces. Feel what happens at the knee. It feels different. That difference is not subjective. It is a change in the distribution of compressive and shear forces across the articular cartilage. Now place one hand on your lower back, just above the pelvis. Walk backward 5 more paces. Feel the lumbar spine. Does it feel less compressed? That is the 46% reduction in intradiscal pressure. You cannot feel pressure in megapascals, but you can feel the difference between a loaded disc and a decompressed disc. The sensation is not relaxation. It is not stretch, it is unloading. Your spine is hydraulic. Reverse walking opens the valve. The applications extend beyond rehabilitation. There is a growing body of research on backward walking for fall prevention in older adults. The mechanism is not strength, it is step initiation. The most common fall mechanism in aging is not a slip or a trip. It is a failure of step initiation, a delay between the detection of instability and the corrective step. That delay increases with age because the basal ganglia lose dopaminergic input. The direct pathway for movement initiation slows. Reverse walking forces step initiation from both legs equally without the dominant leg bias that forward walking entrenches. A 2020 randomized controlled trial from the University of São Paulo took 60 adults over the age of 65 with a history of falls. Half performed forward walking 3 times per week for 12 weeks, half performed backward walking. The backward walking group reduced their fall rate by 53%. The forward walking group reduced theirs by 12%. The difference was not close. The intervention was identical in duration, frequency, and intensity. The only variable was direction. Think about the efficiency. A single activity, no equipment, no cost, no contraindications. The only requirement is a flat stretch of ground without obstacles, 10 minutes per day. The physiological changes occur at the molecular level, the cellular level, the tissue level, the organ level, and the system level simultaneously. Tenocytes realign, synovial fluid diffuses, intradiscal pressure drops, dendritic spines remodel, step initiation latency decreases. All of it from a movement pattern you already know how to perform and stop performing for no reason. Other than that, forward walking feels normal and backward walking feels strange. The strangeness is the mechanism. The brain does not remodel circuits that are running smoothly, it remodels circuits that are failing. Reverse walking manufactures a controlled failure. The failure triggers repair. The repair generalizes. You felt all of this at the start of this discussion, in the 3 steps forward and 3 steps backward before the explanation began. The difference between automatic and supervised, the difference between updating and not updating. The forward steps felt easy, the backward steps felt deliberate. That deliberation was not a feeling, it was a measurement. It was your motor cortex recruiting neurons that forward walking had allowed to atrophy. It was your parietal lobe recalculating your body schema from first principles. It was your vestibular system recalibrating its gain because the expected head acceleration did not match the measured head acceleration. The sensation of strangeness was the sound of your nervous system repairing itself. You just did not know what you were hearing. The smallest daily habit, 10 minutes. One direction reversed. The joint that hurts tomorrow was not built to hurt. It was built to be loaded from multiple angles. You have only been loading it from one. The other direction is still available. Your body remembers the pattern. It is still a walking machine. It is still waiting to be used properly.